Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Dr. Adom Bondzi-Simpson is a general surgery resident and PhD student at the University of Toronto. He's been nationally recognized for his advocacy work and research work on social justice and social determinants of health. He is a winner of the Canadian Medical Association Award for Young Leaders, as well as the 2023 winner of the Mikhael Award for Medical Education from the Resident Doctors of Canada, among many other accolades. In this episode, we do a very deep dive on Adom's upbringing and background and get his thoughts on how we can actually make the House of Surgery a more diverse and welcoming place.
Well, listen, Adom, thank you so much for joining us on the Cold Steel podcast. It's really an honor to have you on the show. I don't really think I need to do any more publicity for you. You're just such a shining star for the general surgery programs across the country. But we're here live at CSF in Winnipeg this year, and so this is a great opportunity for me and for our audience to catch up with you and listen to all the great work that you've been doing. So thank you for joining us on the show.
Well, thank you for having me, Dr. Farouk. I really appreciate it. I know Amir.
Yeah,
so I'll call you
that's
by
right.
First name. So
Adom and I go way back from the days when he was in Calgary. So just for anyone who doesn't know you, can you tell us a little bit about where you grew up and where you did your training?
Yeah. And so, well, first of all, thank you for having me, Amir, and it's a real pleasure to be able to catch up with you after a couple of years and, going back to medical school. So, in terms of where I grew up and where I did my training. So, I was born in Toronto, moved to Niagara just before turning 13. I spent a lot of my childhood playing basketball and running around York University. And my mom was actually she's a teacher, but pursuing a master's and subsequently a PhD in education. So we moved to Niagara when she got her job as an assistant professor at Brock University, which was a big change for us from the city to kind of a more relaxed lifestyle in Niagara. And so we moved over there and I subsequently attended Brock University. I did a health sciences degree program there and was playing varsity basketball over there during those years and was mostly riding the bench, which was great. But I found out I was really a good team morale person. So in my latter 2 years of undergrad, I decided I wanted to transition and really focus in on sort of my academic pursuits. And I wanted to go into medicine. I was fascinated by pathophysiology, and I worked in a vascular biology lab under prof there, Dr. Wang, who was really an instrumental mentor for me. And after doing my undergraduate thesis, I went to Calgary for a master's degree initially. Did a master's in immunology. I worked for a nephrologist over there, Dr. Maruve, who was a fantastic internist, clinician, scientist, extraordinaire, and great mentor. And thought I'd want to be like Dr. Maruve and be a clinician scientist, and subsequently applied to medical school. Was really fortunate enough to get into University of Calgary's medical school and their Leaders in Medicine program, combined master's, MD program. And, thought I'd do internal medicine throughout the first couple of years. And it wasn't until I came across some fantastic residents that were in general surgery, yourself being one of them, a couple others, Dr. Juan Armanon and Dr. Akina Brown, who really kind of, put their arms around me and made it feel like this was a place that I could be in surgery. And so I was really inspired to go into surgery from there. I wanted to sort of come back to Ontario, home, closer to family. I was really fortunate enough to match to general surgery at the University of Toronto. Did 3 years of clinical training in general surgery and really wanted to explore the interaction between health equity and access to care and surgical outcomes. And so I entered into the surgeon scientist training program and currently doing a PhD under supervision of Dr. Julie Hallé, Dr. Natalie Coburn. And so that's currently where I'm at in my journey.
Are there any other graduate degrees you have? You still need to get
This is it. I promise that's it. It's a lifelong learner is really, sort of my motive. So, yeah.
Well, shout out. I want to just take this moment to shout out to Juan Armanon and Akina Brown. They were mentors for me too in residency. They're just fantastic people. So shout out to both Juan and Akina.
Absolutely.
Listen, Adom, you've talked about this before in other venues about your background and growing up in an immigrant family. Mm-hmm. I especially resonate with that, was my dad was an IMG as well. Can you talk a little bit about the experience of your family coming to Canada? Where did they come from, and what was that experience like?
Absolutely. Thank you, Amir, for bringing up the question. I think a lot of us, whether it be an immediate generation or a couple generation back, have an immigrant story in coming into this country. I was the firstborn in Canada in my family. And so, I'm the product of two African immigrants. My mom's family came from South Africa in the 70s, from South Africa, fleeing sort of apartheid over there. And my father came in the late 80s as a student, international student from Ghana. And really, Amir, I was raised in my grandmother's and my mother's home, the South African home. And because we came here as the direct result of refugee, the system of apartheid in South Africa, which was, a system of, sort of oppression for the African indigenous population in South Africa, where it wasn't the same access to education, to jobs, occupation, to material resources. You just weren't able to live out your full human potential. And so, because I grew up in that home, I grew up sort of with the principles of, social justice, of equity, of fairness. And those are some important aspects that kind of shape the way that I see the world through and the lens that I see the world through and how I sort of approach life in my day-to-day being. And so there's one thing, if I can introduce to you, I don't know if you've heard about the term Ubuntu or philosophy Ubuntu.
Oh, I think I've heard about it, but tell me what is it?
Yeah, so I mean, it's become more of a sort of a popular philosophy, but it's a South African philosophy from the Zulu tradition, which is where my grandmother's from, which means I am because you are. And it really just speaks to people's interconnectedness, that shared humanity. And the greeting we say is Sawubona, which means I see you. You're only experienced through the eyes of others, and you exist because of others. So it kind of speaks towards that. And I would say, that's kind of the way I approach life, through that sort of interconnected aspect, and, prioritizing equity and fairness and justice. And it's really because of my upbringing.
It's beautiful. It really is beautiful. My hair is standing on end. It's just it's a beautiful way to see the world. Your mom obviously and grandmother are people who had a huge impact on your life. Your mom sounds like went and pursued higher education. So clearly there's a precedent in the family for lifelong learning. What were your struggles like pursuing surgery or pursuing medicine that you think might have been different? I mean, it's always hard. Nobody else gets to live another person's experience. We only have our own experience. But what was your experience like in terms of pursuing something like medicine and surgery?
Yeah, I think it's when I reflect on the childhood and sort of, I guess, the environment my grandmother and mother cultivated for me, I'm really privileged in that sense. We came as refugees to this country, but my grandmother, who was an educator, she taught in York Region Public School Board for over 20 years. And she really sort of instilled this concept of education. And of course, that's why my mom sort of went back to school and really valued that. And so in a lot of ways, despite that we came to this country as refugees, we ended up being I ended up being quite privileged in that sense, that I had sort of role models to look up to. I had people that I could lean on for sound advice. I had in my mother and grandmother people who really valued my pursuit of medicine, and maybe didn't know the technical aspects of how do you get in, what steps you need to take, and the MCAT. But if that was a goal that I wanted to achieve, they were very encouraging and saying, you can't achieve that. So, I grew up very privileged, I would say, in that sense. And that really sort of instilled in me a confidence that I was able to, achieve some of my goals. So despite sometimes minor setbacks or coming into a place where maybe you're one of only, you might sort of have that built-in resilience that I'm supposed to belong here. I'm supposed to be here. I'm capable of being here. And that was, compounded by the fantastic mentors, that I had. So when I was able to see some of these mentors and they really brought me into this space and made me feel like I belonged in that space, you're able to kind of claim it. And I think that, is part of the reason why mentorship is quite important to me, and how I try to replicate some of the great mentorship you and all the other folks in Calgary, some of the surgeons over there that were fantastic in terms of allowing me to shadow and supported me through CARMS and my residency application. So I'll say their names. Dr. Data, Neil Data was a great mentor of mine. Dr. Hine, a lot of folks at PLC, and Dr. Nixon, who really just kind of, and God rest his soul, invited me into this space. So try to replicate that and be a mentor for others coming in behind me.
I'm curious your thoughts on mentorship, because we'll talk about it, I think, perhaps a little bit again later on in the episode. But mentorship is something that's often thought of as like kind of a cure to our ailments with regards to increasing equity and increasing diversity within things like surgery. And I'll just state it: you're one of the few Black male surgeons in Canada. I mean, there's I think there's more folks like that, but there's not many people like you in the House of Surgery. And I'm curious what your thoughts are on mentorship specifically. Like, we talk about mentorship. How important really is mentorship for you personally, and what does it look like to create mentorship models that actually will encourage the people that we want to bring into the House of Surgery? Like, what does that mentorship model look like?
It's a fantastic question. I think that there's multiple ways that, folks can look at it. The first of way is mentorship in terms of creating opportunities for folks. Whether those be, as I mentioned earlier, when I was a medical student, the opportunity to shadow, and particularly shadow people who were welcoming to learners in that space, right? The other aspect of it is strengthening CVs. And so, in one of the currencies, so to speak, in academic medicine and in surgery is, publications, conferences, et cetera. So bringing students from perhaps groups that maybe they don't have access to go work in a summer lab, in undergrad, or don't have the same access to, maybe they're not a child of somebody who runs a lab or has a research program, and trying to reach out to those groups to provide them with means to strengthen their CVs. And so there's a couple of programs that, sort of run out of the University of Toronto that link students from undergrad, students from medical, students from, equity deserving groups to research programs where they can come in and be successful in terms of strengthening their CV. So I think those type of models are quite important, because it's really more so about, equal opportunity, getting people access, and finding that best and brightest talent from diverse sort of pools and diverse skill sets, because we know that improves our overall outcomes.
Yeah, totally. One of the things I wanted to just touch on before I forget is you wrote this piece for CMAJ called "Where is the Black Doctor?" And I love that piece because first of all, clearly you have a storytelling flair, which just is evocative in the piece, and then I think the message was so powerful. Can you tell us a little bit about the piece that you wrote?
Yeah, I'd love to tell you about it. So, it was a piece that I had wrote in my third year, but on a patient experience and engagement that had happened in my first year that really just kind of sat with me over the next couple of years. And so I was quite an early R1 resident working at one of sort of our downtown sites. And, as you do, it's busy, your pager's blowing up throughout the day, and get a call from the emergency department that there was a patient, 80-something-year-old gentleman that was downstairs with a sigmoid volvulus that was refusing intravenous, was refusing care, and wanted to leave AMA. They said he's quite a difficult patient. Will you come down and come see him? And so, I scurry downstairs to go see the patient. They, you say the sun doesn't set on a closed loop obstruction. So, the urgency of the sigmoid volvulus and to try to detort that volvulus and decompress it. And so I went to go see him. And, just peering through the door, I saw this older gentleman that was there. He was dressed beautifully, but he had a kind of a pain to his face that was there. He was accompanied by a younger gentleman, and I walked into the room, and so I immediately saw a little bit of his guards going down just slightly, and he spoke with a very thick Caribbean accent, and I was able to really just emphasize the urgency of the need for an intervention, that he was actually in quite great shape as an 83-year-old gentleman, and that he had many years, I could see, presumably maybe, to live. But for whatever reason, he really didn't want to engage much with the healthcare system. And so, after lots of discussion with him and his grandson who was in the room, and his daughter on the phone, we're able to, convince him that he needs a scope. And I decided to accompany him to the operating room where we were to do it, or endoscopy suite, I should say. And the surgeon was there, got the consent. And, I wasn't going to be the one doing the procedure. I had a million other consults to go see. And I went out of the room, and all of a sudden I just heard from the next room, "Where's the black doctor?" Right? And the guy's like, "I'm not moving anymore until I kind of have that person that's here with me in the room." And, maybe it felt like kind of like a strange thing. You're like, here's this person that's saying something out loud. Like, why is he having that experience? But I think, upon reflection of that, I think that this was a person that perhaps was maybe feeling unseen within the healthcare context, within the healthcare environment. Later when I went to go wanting to write up the story, I had to speak to the family to get consent. And I had spoken to the daughter, and actually, unfortunately, he had just passed 2 weeks prior. But I had learned that he had grown up in Guyana, of course, which has a legacy of the transatlantic slave trade accordingly with other Caribbean countries in that area. And there's, perhaps a level of, trauma that might be in place with some folks that interact with healthcare settings. And I know someone myself who comes from a South African background, of course, there's stories of people going into healthcare settings for a minor procedure, not coming home. And so there's a little bit of a fear in terms of engaging within systems, whether that be healthcare system, educational system, et cetera. And I think that, although I don't know exactly what he was going through, but I can imagine that seeing me that day perhaps gave a little bit of element of ease to him. And, the takeaway from the story, I think, isn't that providers can't provide care for people that have different backgrounds as them, but rather when we see patients that are navigating these healthcare systems, that are making decisions, that are quote unquote refusing care, that are quote unquote difficult, is to really dive a little bit deeper into what is that cause. And I think that's sort of our role in terms of trying to understand the patient perspective, because we do provide excellent care, but we know that our outcomes, particularly in surgery and elsewhere, they do vary between the social determinants of health. And these sort of, I guess, disparities aren't necessarily old historical disparities, but rather there may be some underlying mechanisms for which we need to sort of understand why patient groups, some are not having the same outcomes as others. So, that experience was quite important to me to write it up, because I thought that, it was a way that I could have a conversation around these difficult, nuanced conversations. But it also was a motivating factor, I would say, to why I wanted to explore some of these in terms of graduate school and my later research and looking at health equity and access to care and outcomes for surgery.
I think you're polite in the way that you phrase things, and you have a gentle way of saying things. But I think we should just be explicit, right? I think this story is a good way of just emphasizing again that you're absolutely right. The disparities continue to exist today.
Mm-hmm.
It's not like something that was in the past.
Mm-hmm.
And we'll talk a little bit about some of the work that you've been doing to try to highlight that. But it's not like these disparities have gone away somehow magically.
Mm-hmm.
I want to just hone in on one piece of this though, which is the looks like me kind of piece to it, right?
Mm-hmm.
I think there's something to be said about when you look across the curtain, so to speak, and you see someone that looks like you. And I completely agree with what you're saying, that it's not about the fact that we all need to, we have to have the same background as someone to be able to treat them. But unless we have those voices at the table collectively, we don't have that ability. I would postulate, we don't have that ability to really understand or empathize with the person sitting across from us. I'm curious, and there's been, I don't want to land you in hot water, and maybe this conversation is bigger than our podcast can handle, but there's been so much debate over the years about, pipelines for folks to try to get disadvantaged or minorities into, let's say, university, for example, or medical school, right? There have been these programs for many, many years at various places about specifically targeting underrepresented minorities and making sure they get into medical school or into surgical residency or whatever the case might be. I'm curious what your thoughts specifically are on this idea of, making pathways for underrepresented minorities to be in healthcare.
Yeah, it's a fantastic question and a multi-pronged question for which, I could probably provide my perspective. I would never sort of be, at least at this point in my career, feel like I was an expert in the topic, certainly, but can share some of my insight, what the phraseology sort of looks like me. I think that it's one component. It's an important component, I think, of care in terms of providing culturally competent, safe, inclusive environments for patients. Not the only component, but an important component. And I think that it matters because, it can improve our overall outcomes. I think that to your point about improving pipelines for learners that come from underrepresented backgrounds, I think there's a couple arguments that can be made about it. The first argument is that perhaps our medical spaces, our environments, or our schools, whatever it could be, our justice departments, should reflect of that of our society in general. So, and that should be sort of whether that be the gender, race, ethnicity, religion, it should be sort of a reflection of our society. And I think that's probably more so like the moral argument about fairness, about sort of equal opportunity, about finding talent from all different diverse sort of resource pools. So that's sort of, I think, the moral argument. The other argument about it comes from like the outcome perspective. So we know that patients, for instance, that are treated, and there's been a number of sort of body of literature coming from the United States, showing that patients that are treated from care providers that are sort of racially concordant, that it can actually improve some of those outcomes. And there's been a lot of data around infant mortality with respect to that. The other component of it, I think, is it's about sort of equal opportunity, I think. And so when I think about these models of these programs, I think that it's more so about improving the outcomes of our patients, more so about sort of reflecting that diversity, which is within our society sort of at large. And I think that can improve our sort of overall quality and patient-related outcomes.
Yeah. Obviously, this is not asking you to figure out for us whether affirmative action works, right?
Yeah.
That's a huge topic.
Yeah.
But I think it's important, at the very least, for us to have conversations about it, and for programs across the country, medical schools across the country, to think about actively whether our initiatives are working or not. Because I'll tell you that maybe I shouldn't say this on air, but like I have some deep-seated distrust or mistrust of a lot of EDI, equity, diversity, inclusion initiatives, in the sense that I often feel like we don't know which ones work.
Yeah.
I often feel like it's rubber stamping. I often feel like it's a corporate way for organizations to feel like they've done their part.
Mm-hmm.
And I'm not convinced that they work. I'm not convinced that it's done from a place of genuine sincerity, that we want to focus on the things that you talked about in terms of both patient outcomes, but also like making the workplace and the house of surgery an inclusive and welcoming place for everyone.
Mm-hmm.
I'm curious, again, I'm asking you like all the big questions, because why not, right? Why not? But what do you think about equity, diversity, and inclusion initiatives? Are there any things that you've seen, initiatives that you've seen either locally or other places that you think have worked? Give us your sort of 30,000-foot view.
Yeah. Amir, I think about sort of equity, diversity, inclusion, really about the concept that, like at its core, it's about ensuring that people can live out their best lives to their best human potential. And I think in healthcare settings, that patients can have the highest quality outcomes, let's say, irrespective of their social factors, i.e., their sex, gender, race, religion, education, access to material resources and needs. I think that sort of from our healthcare provider perspective is an important component of quality, right? We think about the Institute of Medicine's 6 pillars of quality in terms of timely, patient-centered, safe, effective, and the last one is equitable, right? So it's a real important, I think, component of quality care. So, when I think about equity-based initiatives, I think about them as sort of being centered in this idea that we want to get the best talent from the most diverse places. And I mean, it's a little bit out of my expertise to speak about different kinds and models, but I can speak to you about some of the ones that I'm involved with, myself. And so, for instance, one of them is called Upsurge, an initiative that I've been very closely aligned with, and is really the brainchild of our faculty lead, Dr. Sav Brar, and along with myself and my colleagues, Dr. Betty Yebrahu and Dr. Amanpreet Brar, started the initiative back in 2020 to really try to improve the diversity within our surgical spaces, our house of surgery, as you mentioned it. And really it's to stimulate interest for students that come from underrepresented groups, whether those be Black and Indigenous groups, students that come from 2S LGBTQ communities, rural students with background of different socioeconomic need. And really the vision was to provide a space where the students could have access to some resources, but access to some mentors as well. And we've been really blown away by the need for this type of program and the interest that the students have had. So, in our first year, we had 70 students or so matched into the program, matched them with surgeons in the community and academic settings. And over this last year, we've had over 130 students apply with programs sort of across the country, with one starting up at University of British Columbia, Calgary, in Ottawa, and in Winnipeg over here. And one of the important areas, I think, too, is about going a little bit upstream from even medical school. And so most recently, we started some outreach for local high schools. And so we do that in the GTA, and actually we've had a great turnout over here at CSF, partnering with CAGS and the CAGS Foundation to bring the programming in. So we've had a group of 23 high school students from a local high school here, Gordon Bell High School, come in and just be able to interact with surgeons, with residents, and do some simulation. We got a bowel and anastomosis simulation, vascular, some FLS, and you'd be surprised, Amir, how good they are on those sticks.
all that Fortnite.
Yeah, right? Exactly. They're next level when it comes. And we've been able to partner with Ethicon, who provided them with some virtual reality goggles and sutures, and really just get them fired up about surgery, about the opportunity that this is a space that's for you, and a space that you can occupy and be in and excel and thrive in. So we've had a lot of success with that. We had a panel session as well, where the students could ask questions to surgeons and residents. So I think about initiatives as being rooted in in those types of causes. The causes being that we want to try to improve access to people that come from all different walks of life, because I think some of the strong evidence for it is that, it is something that, patients are looking for. It's something that can improve our overall health outcomes, but also to, people had looked in, the financial world and seen that there's, sort of diversity improves the bottom line in terms of revenue, in terms of our outcomes. And yeah, that's the main thing.
Yeah. I don't know if you've read that book by Scott Page, but he makes very eloquent arguments about simply having having a more diverse company leads to better outcomes. So if that was the only reason, leaving aside all the other things that you so eloquently talked about, there's a very strong argument for why that makes a big difference. So for Upsurge, is this a longitudinal relationship that these students have, or are these more one-off events, or how does that look like?
Yeah, so there's a couple of different arms of the program. So the flagship and how we started the program was with mentorship for medical students, which certainly there's that longitudinal component. They're matched with a surgeon or a senior resident or a fellow, and they're able to have a long-term relationship with that person. We also provide them with some simulation workshops to kind of hone their skills, including things like getting ready for CARMs, how to be a good clerk when you get on rotation, interview skills when we're talking about CARMs applications as well. So that's sort of the mentorship program for the proper. We also have the outreach initiatives, which has been targeted at high school students and even going back all the way to elementary. And, at this point, we really kind of run them as one-offs, but certainly that's something that we're going to be looking forward to, is to try to cultivate some type of long-term relationship, but also to a staggered relationship. So, probably the most relevant thing for those students at that point is their next target is getting into undergrad and their next target is getting into medical school. So, one of the things that we were excited about with this initiative over here is that we teamed up with a local Upsurge chapter here in Winnipeg that's run by the medical students. And, we're mentoring the medical students, but the medical students were really ones that were mentoring the high school students. And we're excited that the medical students will sort of be facilitating and fostering sort of a long-term relationship with the high school students, so that they can get some of that nearer peer advice to, undergrad, success in undergrad, MCAT, and those types of things. So something we haven't yet done, but something we're looking to intentionally carve into the program moving forward.
That's fantastic. I do want to highlight some of the research work that you're doing. You're obviously embarking on a PhD. Can you talk to us a little bit about your PhD that you're doing, and you've actually done some work already that have talked about health inequities in research. One of the papers that I wanted to highlight was did a narrative review on integrating equity frameworks into surgical quality improvement in health administrative databases. Maybe you can tell us about your PhD, and then maybe talk a little bit about this paper specifically.
I'd be happy to. So I'm currently pursuing a PhD in clinical epidemiology and healthcare research. I've been tremendously grateful and lucky to have great supervisors. So Dr. Julie Halley is my supervisor, and Dr. Natalie Coburn as well. Really cultivated an environment where I could pursue my academic interests, but also to some of those other those advocacy related things as well. And so broadly speaking, I'm interested in the intersection between health equity and cancer surgery outcomes. And particularly my thesis is looking at the role of association of social determinants of health with quality metrics for colorectal cancer care. And more specifically, I'm looking at wait times for colorectal cancer and how wait times may vary according to social determinants of health. We use in our lab large population-based data sets in Ontario to explore those associations. And some of the work that we're currently looking at is exploring sort of how those social factors influence wait times, but also two other factors such as adjuvant chemotherapy in patients that are eligible, surgically resected stage 3 colon cancer, for example, for which I'll be talking on Saturday at the colorectal meeting about some of that research. But other in-hospital measures, quality metrics such as failure to rescue, and really exploring along the cancer care continuum from initial presentation to survivorship care is how do these social factors influence our achievement of those quality metrics. And so I'm really interested in sort of that piece. The piece that you brought up about from the American Journal of Surgery, the narrative review, was it sort of comes from the concept of we're unable to tell if we have disparities within our cancer systems, within our surgical health systems, if we explore them. And one of the ways that we are able to measure them is if we collect some of that data up front. So we're interested in exploring utilizing the Canadian Institutes of Health Information, CIHI's equity stratifier toolkit, which outlines sort of a real guidance on how administrative data sets can collect social determinants of health, age, sex, gender, Indigenous identity, race, education, socioeconomic status, real good guidelines on that. So we want to explore the main databases that we use for from our surgical research. So ICAS, for instance, in Ontario, BC Pop in BC. We looked at Winnipeg as a population data set. We also looked at data sets from the American College of Surgeons, the Society of Thoracic Surgeons, and just asked the question, what social variables do we even collect? We saw that there's tremendous sort of variation in the types of variables we collect. Not only one, if we collect them or not, but even two, in terms of how we code those things, which is really important for a researcher's ability to be able to assess if there's disparities that exist. And from a healthcare policy perspective, how we can address when there is a disparity from a health policies and allocation of resource perspective. So that's sort of what that piece is, and really sort of where my overall sort of research interests lie.
Yeah, it's hard to fix a problem that you can't even quantify, right?
Yeah, absolutely.
Yeah, I think that work is extremely valuable. Listen, Adom, it's been really a pleasure having you on the podcast. You know, as someone who saw you when I was I think in R1 and you were still a medical student, it's been really amazing to see you grow and progress and I think lean into your power, right? Like lean into your strengths and uniqueness and what makes you. And you've been recognized now by CMA, all these amazing awards that you've won. So really, it's been a pleasure having you on the show. What's next for Dr. Bondzi-Simpson? Where do you, obviously you're going to do your PhD. What sort of things are on the horizon for you next?
Thank you, Mir. Well, I mean, on the horizon certainly is completing the PhD, getting back to clinical work and finishing off that sort of part of the journey. But I think for me, I really want to explore, sort of those associations between social structures, policies, and healthcare outcomes for our surgical patients, and looking at it through the lens of research, but also too in terms of the types of advocacy I do. I think that the ultimate goal is to bring about equitable access to healthcare such that patients can live out their full and human potential. And so, as technologies advance, I think it'll probably be our mission sort of in this generation to ensure that equitable distribution of technologies to best serve our communities. And so I think that'll be our mission. And that's sort of where I hope to make my contribution in moving forward. And it'll be a nice journey to go on.
Do you have any specific advice for someone who is interested specifically in equity in surgery? And also more broadly, what advice do you have to trainees about pursuing their passions and turning their passions into hopefully fulfilling careers?
Wow. Well, yeah, it's a fantastic question, and you're certainly right. You're seeing a lot of different folks using some of the same lines in their Twitter announcements. But I think that it's important to find people that are doing the work, particularly surgeons, but even outside of your own initial divisions and departments, to look at people in different spaces. This work is, and this is another buzzword, but intersectional in nature, where you're getting together social epidemiologists, biostatisticians, healthcare providers, sociologists, education folks, people in health policy and grassroots. So try to find those people in those spaces. And it might be just outside of your own department or a little bit down the street in terms of your academic departments, but try to find those folks that are doing the work, and you'd be amazed at how much you can learn from different folks in different environments outside of our sort of surgical spaces. And the second part was, what advice?
Yeah, what advice would you have for people who are interested in trying to figure out how to turn their passions and what makes them unique into a career? Correct me if I'm wrong, but when I see your trajectory, I think that you're someone who has taken something that's meaningful to you and turned it into something that's been really meaningful and powerful, and something that you've been recognized for across the country.
Yeah, so I think with that, you know, it's important to your exact point, try to think about those things that matter most to you, that make you unique, but are in sense that they're unique to you, and try to stay true to those, right? The tide may shift, you know, sort of certainly after 2020, sort of social justice movements, these topics got put to the forefront, but there might be a time when, you know, they sort of come out of vogue, so to speak, and we're seeing some of that now even. But, you know, if you're sticking to things that interest you, that are a part of your passion, that are a part of sort of your DNA, so to speak, then you're able to carve out a lane for yourself that's kind of authentically yours, you know? And when you think about the things in terms of, you know, I've had a mentor that once said this, that he said, I might not be the best, you know, a general surgeon. I might not be the best person in computer science. I might not be the best administrator. But when you put all those things together, it's really a unique person. So when you're able to carve out that space, and when you add up all those little unique things that make you, it really brings together something that's interesting and unique. So stay true to yourself and keep at it.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.